Welcome, everybody, to the Cone of Shame Veterinary Podcast. I am your host, Dr. Andy Roark. Guys, I got a good one for you today. I am here with Dr. Cory Woliver from the University of Florida's College of Veterinary Medicine, and we're doing a snake bite case. You know, it makes me nervous. I'm here in the South, in South Carolina, and we've got a lot of copperheads. We've got eastern diamondback rattlesnakes, and we've got some cottonmouths, things like that. And so I see dogs come rolling in, and they're usually bitten in a front foot or bitten in the face because they stuck their snout down there and made a friend. And so anyway, I'm just looking at that, and I want to work with Cory a little bit here and just make sure that I am up to speed with what I should be doing. And I know we talk a lot about pain control in snake bites, and we get into that in the episode. We talk a lot about dosing of anti-venom, and I'm looking for some clear guidelines about use this many vials for this, and I think it's more art than science. Unfortunately, I think that's where we are right now. But it's great to hear someone who is very, very experienced talk about kind of how he thinks and what he does. And I think it's a really, really useful episode. So the nice thing is we sort of start talking about snakes, and we don't really identify a type of snake. And Cory's sort of like, it doesn't really matter in the way that we treat them. I love to hear that. So this is a one-stop shop. All you need to take care of your snake bite cases. Let's get into it.
This is your show. We're glad you're here. We want to help you in your veterinary career. Welcome to the Cone of Shame with Dr. Andy Roark.
Welcome to the podcast, Dr. Cory Woliver. How are you, my friend?
I'm good. How are you?
Man, I'm great. I'm really glad to get to talk to you. You and I, we're just going to talk for the first time right now. You are a good friend of my good friend, Dr. Phil Richmond, and I was talking to him about a case, and he was like, well, I know who you need to talk to. And that's how your name came up, and we got introduced. And you are, for those who don't know, you are a practicing veterinarian. You are a clinical lecturer in emergency critical care at the University of Florida's College of Vet Medicine. That does not mean that you're a stand at the front of the room lecturer teacher. It means that you're the guy on the emergency critical care rotation, which means you hang out all night with vet students is what that means to me.
Pretty much.
I wanted to have you in today to talk about this case. So you have a really strong interest in venomation, in snakes in general. You're sitting in front of terraria that are filled with various species of herps, and I just love it. I'm a big herp guy, so I love it. I want to make sure that I'm still working these cases up correctly. So I am in South Carolina. As we're recording this, it is the summer in South Carolina. It is a very snaky time and place for us. So I have a lot of copperheads, and then the eastern diamondback rattlesnake is here. Those are really the two big ones that I say. We do have cottonmouths here in this area as well and stuff like that, but those are sort of the big ones. I saw a 3-year-old male-neutered Boykin Spaniel named Boykin. They call it his first name. They're like, he's just Boykin. He's a Boykin Spaniel, so he's sort of a hunting dog that came in. These roll into our practice quite a bit. And so he comes in, his right lip is big and swollen and painful. And you can see what looks like two little punctures in his lip. And you can see it because the lip is so sort of swollen. And it's just, at this point, just really just red and angry. And the owners say, yeah, we think he got bitten by a snake, and we have no idea what kind it was. We didn't see it. They don't have any defining characteristics for me, anything like that. The dog they heard him yelp, and when they found him, this is what he looked like. And so walk me through this sort of case. So let's say this comes into you on emergency. How do you start to look at these cases if it's a highly likely snake bite?
It's like anything, start with a physical exam, examine the puncture wounds, get the patient's vitals. It's all really important to see how stable they are and what other things we may need to do to try and stabilize them. But in general, what we'll do is we'll start with just a minimum database of some sort. So one of the most important things is getting coagulation times. We'll try to get a CBC chem if finances allow. And it's one of those things where if we're not sure if it's a snake bite, we will check a blood film and look for signs of echinocytes and see if there's evidence of echinocytosis on there. We can also get a manual platelet count from there as well if we can't get a CBC.
Break that down for me really quick. So it sounds to me like you're doing a coag time over a CBC if you have to pick. If they're just like...
If I had to pick something, I generally do either a PT-PTT, or at our practice we use an ACT or an activated clotting time test.
And so when you're looking at this, what are you looking for? What are the big rule-ins, rule-outs? If you have delayed clotting time, like what does that mean for you? I'm imagining that you're sort of working through an algorithm, a treatment algorithm here. So tell me about that.
Yeah, so if we do see evidence of prolonged clotting times, that often tells us that the bite tends to be a little bit more severe. And, we may see some other issues. We can see bleeding, we'll sometimes see necrosis, we'll see swelling, pain, stuff like that. But generally, the more prolonged the clotting times are, the more aggressive we'll need to be with anti-venom.
That's super helpful. Let's say that we got a little bit of a prolonged clotting time here. And again, this is early. I said the lip is swollen, but it's not out of control. But let's just say that they brought Boykin straight into the clinic. And so you're looking at it, you've got a prolonged clotting time. Otherwise, physical exam seems normal. He seems painful. Where are you thinking about going from here?
What we'll typically do is we will make sure that the patient is stable, sometimes give them fluids, pain meds, things like that. But then we go ahead, we'll treat them with antivenom. When we are treating with antivenom, the big thing is that we are not actually treating the patient with antivenom. We are treating the venom that's been injected. And that's a big misconception when treating snake bites. It's like, oh, it's a large dog, they don't need antivenom, or a small dog necessarily needs a lot of antivenom. It's not dose dependent on the pet, but it's dose dependent on the volume of venom injected. So we kind of have to gauge how much venom we're going to be neutralizing, and that's often based on coags and how stable the patient is and how much swelling there is and the severity of the pain and things like that.
This feels a lot like when I started in practice, I had this mentor and like his go-to was triamcinolone, right? Like that was his steroid of choice was Vetilog. And I was like, how do you dose this? And he was just like, you just kind of feel it. And I'm like, it was the least helpful advice ever. But he was more like, it's just what's in your heart. And that's kind of what I'm hearing from you is like, it feels like it's what's in your heart. Is there more science to it, or is it really just based on experience and the specific anti-venom that you're using? How do you sort that out when it's not something that you've done over and over and seen the results of?
So it is kind of yes to all of the above to what you just said. I mean, to some degree, it's experience. To some degree, there are certain milligrams of antivenom to neutralize, or vials of antivenom to neutralize milligrams of venom injected. But the thing is, we never know how much venom has been injected. So that's where kind of experience comes into play there. When you see, hundreds of snake bites, okay, this one might be a little bit less severe. This one might be more severe. I mean, we just had a case at our hospital that the patient needed 50 vials of antivenom. It's very patient dependent.
So do you have any sort of a corollary that you use between like your coag results and your vials? Is that the main driver that you're kind of using here? I'm just trying to dig a little bit of like, I wouldn't know where to start. I'm like, are we at 10 vials? Are we at 3 vials? Are we at 30 vials? I'm sort of looking for clarity there.
So to some degree, yes. And, with our clotting time machine, it'll count up to 999 seconds is the high end of where the machine can count, and it just maxes out there. And for a lot of our really bad rattlesnake bites, we will see it get that high. So we know for a lot of those, those are probably going to need somewhere in the starting range of 4 to 6 vials of antivenom just to maybe even stabilize the patient. Sometimes we need more. Sometimes it ends up being more than it needs, but it's definitely better to overtreat than undertreat.
Yeah, so that totally makes the overtreat versus undertreat. Do you end up staggering it? Do you end up saying, like, let's start with 3 vials, and then you watch and you're like, better add another vial? Like, is it an ongoing process where you watch and you continue to monitor like that? Or do you just try to go heavy at the very beginning and say, let's be aggressive, and then not have to worry about if we gave enough or not?
I tend to be a little bit more aggressive up front for, what appear to be the more severe bites where we have these extremely tachycardic, hypotensive, actively bleeding animals. I'll start with 4 to 6 vials and bolus them over minutes. And we say, let's see if, how this goes over like an hour with 1 or 2 vials, because that patient will die in front of you sometimes that way for the more severe bites.
Okay, I'm picking up what you're putting down. All right. Yes, you have my attention. What do you look for in an anti-venom, right? So, I mean, are there industry standards? Are there a certain, I don't know, just so in picking out what you're going to use, are there ones that you go to and are there ones that you stay away from? Help me understand that.
So in veterinary medicine, we have access to 2 different products. We have VenomVet and we have Rattler. Both will treat any and all snake bites throughout North America. So whether it's a copperhead, a cottonmouth, or any rattlesnake, they will both treat those bites. They do have, their variations in composition. So the vet product is a Fab 2 product. So it's a little bit more broken down into smaller fragments, where the Rattler product is a full IgG molecule. It's a frozen product suspended in equine, a small amount of equine plasma. So that comes in 50 mil aliquots, and then the Venom Vet product comes in 10 mil aliquots.
When I was starting my career, the thing I heard about anti-venom is it's expensive and it doesn't last that long. Is that still the case, or do you feel like we've made progress as far as shelf life for these products?
So shelf life for these guys is about 3 years for both products. I'd say it's got a pretty decent shelf life.
So that makes sense for me. All right. So we're talking about anti-venom. Well, we've got our dog. We've bringing him in. He's a Boykin Spaniel. We've looked at the coag times. They're slightly prolonged. We're going to go ahead and start with a dose and pick out however many vials we're going to try to use with this dog. Talk to me about sort of supportive care from here. So we've done the anti-venom. Let me just start internally. You're always hospitalizing these patients. I'm assuming, is outpatient therapy even on the table, or is that just a no?
It is for more minor bites and some of the mild, moderate bites where finances may not allow hospitalization. We'll certainly do outpatient. For the more severe bites that are really unstable, that's not usually a possibility. But for a bite that's got some mild swelling, mild pain, ongoing hemolysis, or anything like that, outpatient treatment with some IV fluids, some pain medications, a dose or two of anti-venom.
Talk to me a bit about your pain medications. What are you reaching for here?
So I usually reach for strong opioids, and specifically ones that are easily reversible. So I'm probably not going to reach for something like butorphanol or something like that, because you can't really reverse that, and it's not great for pain control. So things like methadone is my usual go-to. Sometimes if methadone's not there, I'll do hydromorphone or buprenorphine, but ideally strong but reversible opioids overall would do the trick.
Are you doing any sort of an anti-inflammatory therapy, like whether it's steroids or NSAIDs, or is there anything like that we reach for? There was a hubbub a number of years ago. There was a television veterinarian that had a snake bite, and they were like, steroids, that's what we go for. And there was a lot of people who did not like that advice in the vet community. Can you talk a little bit about why that is?
Yeah, so both in human guidelines and in what we have in veterinary medicine, it's never been shown to help. There was a paper out of CSU 15, 20 years ago that showed all it did was raise the neutrophil count. It didn't do anything to aid their recovery, decrease their pain, anything like that. It was just a neutrophil count increase, which doesn't mean anything. The things that we do worry about with steroids are things like delayed healing. So for patients that develop necrosis, we worry about delayed wound healing. And then theoretically, patients who might be shocky to some degree, you give them a steroid and we worry about, is their stomach going to perforate now from the decreased gastric perfusion?
I don't know why, Cory, but whenever I see a dog that's got like that swollen lip or a snake bite, and they often get bit in the face, they're just sticking their face right up in there. My first thought is, I hope this dog's lip doesn't slough off. And I don't know why I have that thought, but I do, and it definitely sort of bothers me. And when I'm looking at this dog, I'm looking at Boykin, and he's got this swollen lip on the right side. And it's just, right now, it seems to be getting larger. Talk to me a little bit about tissue necrosis, things like that. How much of a concern is that for you? Are there warning signs? Are there red flags where you say this might be a significant problem? Is it just a wait and see sort of approach and push your fluids, really try to increase perfusion? Walk me through, how concerned are you about that? And then what do you do to try to manage it?
Anti-venom is still the best thing to manage it. It doesn't always get into the tissue super well. So the best thing you can do is actually get it into circulation and out of the area where it's confined to. In human medicine, one of the things they'll do is they'll often have them raise their limbs like above their heart level to try and increase lymphatic drainage of that area and get it more into circulation. And reasons they don't recommend tourniquets and things like that, because the more trapped it is in that area, the more likely it is to cause local problems. It's hard to get a dog to raise their head and keep it raised for hours at a time or have a limb raised, but anti-venom's the best thing we have that may prevent necrosis from setting in, but sometimes you have to get it into them super, super, super early, and no matter what you do, sometimes the necrosis still develops.
Do you set expectations around that with the pet owner? What do you say to them? Do you say this is a possibility?
Yeah, I always warn them that it's a possibility. And no matter how aggressively we treat, no matter if the pet was bit right outside the clinic and we start it within 5 minutes of the bite, I mean, it's always a possibility that necrosis may set in, and then it's wound care from that point on.
What do you know now about treating snake bites that you wish you had known earlier in your career? Like, you do this a lot, and it's obviously something that you've really focused on. What were you wrong about early in your career, or what do you wish you knew?
Where I was trained, we weren't nearly as aggressive with anti-venom as we are here at UF. Granted, the snake bites are a lot more severe where I am at the moment, so that definitely plays into it. But kind of makes me wonder, the patients that I would have given 1 or 2 vials to, back when I was an intern or whatnot, if I would have given them 4 or 6 vials, would they have developed that severe amount of necrosis regardless?
We all have those cases that we look back at and go, I wonder if I had done this differently, how it might have gone. Is that the most common mistake that you think you see today, is sort of underdosing? If I said, do you think about the cases that you see or the GP workups that you see, is underdosing on anti-venom the number one most common sort of misstep that you see people getting into?
Yeah, and some people just don't realize that, sometimes 2 or 3 vials isn't enough. Sometimes these really bad bites need 10, 20, 30 plus vials. And to recognize, to say, okay, this patient really isn't stable, this patient really needs more anti-venom is really important. And that's something that, unless you're like truly trained to do that, like, that's not an instinctive thing to do. That's something that's very nuanced.
What do you think the second most common mistake is?
I still see a lot of people get NSAIDs, steroids, Benadryl. Those are still big things sometimes that we'll see, especially over at National Snake Bite Support, where we get a lot of people asking us questions about how should my pet be managed or how should I manage this patient. And a lot of these patients will get those medications and we'll be like, those aren't really super helpful. The other thing that we'll sometimes see is just antibiotics right off the bat. Unless an infection's actually set in, we usually avoid antibiotics. There was a paper, I think, out of Arizona that showed only about 1% of snake bites will actually truly develop an infection. So to use them prophylactically doesn't necessarily change the outcome, except you may end up with a resistant bug.
That totally makes sense. All of those things are things that I've heard discussed, the antibiotic coverage, and whether it's because it's a puncture wound, it's a bite wound, or because this is helping us in case we have necrosis and we don't want secondary infection and things like that. Then obviously the pain control is the thing that I hear discussed the most. Cory, this is fantastic. Tell me about the National Snake Bite Support Group.
So it's a group that I joined like 5 or 6 years ago. It's a non-for-profit group that connects snake bite victims or patients with people who are experts in treating snake bites, and allows these patients to get proper care, proper guidance, practitioners to ask advice, especially in more difficult cases. And it's been really, really great. And we've helped lots of pets, and on the human side of things, they've helped lots and lots of people.
So if you have someone who's a veterinarian or a veterinary technician who just thinks that this is a really interesting area in medicine and they want to kind of learn more, sharpen their skills, build their own experience, just hear more about cases involving snakes and snake bites, how do you recommend they get started?
So yeah, National Snake Bite Support's a great starting point. And we have so much information both on the Facebook group and on our website and everything like that. And then, if there's specific questions, that's what we're there for. We're there to answer them and guide people through these kind of things and point them to the literature and things like that.
Outstanding. Well, Cory, where can people find you online? Where can they follow what you're up to?
So National Snake Bite Support's a great spot to find me. The Asclepias Snake Bite Foundation is another not-for-profit group that we work with. That's mostly overseas management of snake bites. They have a couple of clinics in Africa that have really increased the standard of care for that. And then I have my own snake bite page, basically. It's Cory Woliver DVM on Facebook that I'll post snake bite articles and other things on.
I'll put some links in the show notes so that people can find that stuff and check it out. Cory, thanks so much for being here. I appreciate your time. Guys, thanks for tuning in, everybody. Take care of yourselves.
Thanks so much for having me.
And that's what we got. Guys, thanks for being here. I hope you enjoyed it. I hope you got something out of it the next time that Boykin comes rolling through the door with a swollen lip and 2 puncture wounds. I hope you have a good idea what to do and you get to smile and say, I know how to handle this. So that's what I hope for you. Anyway, take care of yourselves, gang. I'll talk to you guys later on.